Welcome back, everyone. Please come on in and take a seat. Feel free to go grab more coffee at any point. So we're gonna go ahead with our next panel. What's the situation? Understanding global data for adolescent well-being. Right. So I, again, get the pleasure of introducing the moderator for our next panel. So with a clinical background in nursing, Mansurat Raji bridges research and practice to advance global mental health, particularly in underserved and humanitarian context. Mansurat actually co-led the development of Nigeria's Adolescent and Young People's Health and Development Implementation Plan for the periods of 2019 through 2024. So without further ado, I'd like to welcome her to the stage so she can tell you more about our panelist and who you'll be hearing from today.
Hi, everyone. Good morning. My name is Mansurat, as I have been introduced, and I am honored to be here and delighted to moderate this panel. So I am going to take a minute. I am a very, very fast speaker, and a couple of wise people in this room once told me to slow down when you're talking because you want to keep everyone engaged and connected. And this convening is centered around a call for action. So it is imperative and important that we carry everyone along and we all connect with each other. So if you feel like I am doing a good job keeping the pace and you can hear me clearly and audibly, can I see a show of hands? Woo-hoo! All right, thank you so much. They are going to be proud of me. So, thank you once again for being here. I would like to introduce speakers for this panel. First, Dr. Shoshanna Fine, who is an assistant research professor at the Johns Hopkins Bloomberg School of Public Health, and Dr. Jennifer Seager, who is an associate professor at the Milken Institute School of Public Health at the George Washington University. Welcome. So a few housekeeping notes. We have two presentations. These presentations are on describing findings from two major studies and elaborating on the current situation and the mental health needs for young people and adolescents. So each presenter has 15 minutes. We will do our best to keep to time, 15 minutes each for the presentations, and followed by a moderated discussion and audience questions. There are microphones on both sides, and please raise your hands, or you can walk down to the speakers over there and someone will bring a mic to you, or you can walk down there. So thank you so much for joining us once again for such a timely and critical conversation. And I will call upon Dr. Shoshanna Fine for our first presentation. And I promise we are not going to bore you with too much data. I know it's a lot to take in, but we'll do our best to keep it very lively. Thank you.
There's going to be a little data.
It might work. We'll see. All right. Yeah, look at that. All right. Thank you, Mansurat, for that introduction. As Mansurat mentioned, I'm an assistant research professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. And my work largely focuses on adolescent mental health and well-being in low-resource settings. And I'm really delighted today to have the opportunity to help frame our discussion over the next few days by providing some data. Like I said, there will be some data from young people around the globe. I'm going to do something today that's maybe just a little bit risky in a 15-minute presentation, and that is to briefly present some findings from 3 separate cross-national studies that I've worked closely on. And the reason that I want to focus on all 3 is that they take very different approaches to understanding mental health in this age group. And as a result, I think that when they're viewed collectively, they give us a much more nuanced understanding of what adolescent mental health looks like around the globe. I don't think I need to spend too much time today convincing this particular audience of why it's important to focus on mental health in adolescence, and I think we heard that this morning across the presentations. But instead, I want to start us off by sharing upfront what I think are 3 simple but really important messages from the studies I'm going to talk about today. First, that there's an important distinction between distress versus disorder. And this distinction needs to fundamentally drive the ways in which we understand and respond to adolescent mental health challenges. Second, that in order to address adolescent mental health and well-being, we need to focus on the context within which adolescents live. And there's a lot of really important variation across these contexts. And finally, that adolescents around the world face really steep barriers to getting both formal and informal support when they're in need. Now, as I'm sure you're all aware, over the past several years, there's been an increasing spotlight globally on adolescent mental health. I'd say that one of the biggest reasons for this, understandably, was the COVID-19 pandemic. But also there are growing concerns around the impacts of other new and increasing threats, including the rise of social media culture, climate change, political upheaval, and armed conflict, among others. And in part because of all of these different issues, you really only have to look at a newspaper right now to hear about what's been labeled as the youth mental health crisis. So pretty much all of the headlines on this slide come from the past 6 months. And these examples are barely scratching the surface of what's been published over the past few years. Of course, in order to unpack the nature and the scope of a potential youth mental health crisis, we need to turn to actual data. And so that brings me to the first study I'm going to discuss today, the National Adolescent Mental Health Surveys, or NAMS, which was implemented back in 2021. The central goal of NAMS was to measure the prevalence of 6 common mental disorders among adolescents aged 10 to 17 in 3 low and middle income countries, Kenya, Indonesia, and Vietnam. And a secondary goal was to produce data that met criteria for inclusion in the Global Burden of Disease study. I'm not going to go into the methods of NAMS in any great depth, but there are a few things that I want to highlight here. First, each of the 3 participating countries in NAMS implemented a nationally representative household-based survey of adolescents with between around 5,000 and 6,000 participants in each country. Also, as I mentioned before, the goal in each country was to measure mental disorders that are thought to be pretty common in adolescence. And that specifically included major depressive disorder, generalized anxiety disorder, social phobia, PTSD, conduct disorder, and ADHD. And the measurement of these mental disorders relied on the Diagnostic Interview Schedule for Children, or DISC-5, which, as you may know, is intended to make a diagnosis of mental disorders according to standardized DSM-5 criteria. Now, we did follow a process of cultural adaptation prior to using the DISC-5 in each country, but it remains a highly structured and rigid measurement tool, as you can see from the snapshot of the DISC-5 module for major depressive disorder, which is included on this slide. And so overall, I think we can label this as a top-down approach to understanding mental health in this age group. So here's the prevalence of mental disorders among adolescents in Kenya, Indonesia, and Vietnam in the past year, according to NAMS. Now, one frequently cited statistic, which I think we heard this morning in Dr. Collins' presentation, is that mental disorders affect around 10 to 20% of adolescents globally. And those estimates actually generally predate COVID and other recent global challenges. And so we might assume that even more adolescents would be impacted in 2021 when this study was conducted. What I think should jump out right away from this table is that these prevalence estimates are actually fairly low. For example, looking at Indonesia and Vietnam, only 5.5% of adolescents in Indonesia and 3.3% of adolescents in Vietnam had a mental disorder. And if you look at something like depression in these two countries, which is generally thought to be quite common in adolescents, we see a prevalence of around 1% or less. By comparison, the prevalence estimates were considerably higher in Kenya, where 12.1% of adolescents had a mental disorder, but even there, only 2% had depression. I think these data tell a somewhat different story when you look at how many adolescents in these settings are actually able to access support for dealing with mental health challenges. So here you can see the prevalence of adolescents in NAMS who had used mental health services in the past year, which we defined as any support or counseling for emotional or behavioral problems, so quite a broad definition of services. This question was asked for all adolescents, regardless of their mental disorder status. And what you can see here is that very few adolescents who either met the criteria for a mental disorder or who didn't meet the criteria but still had elevated symptoms had accessed any type of services in the past year. For example, among those adolescents with a mental disorder, less than 1 in 8 had used services in any country. So this really highlights substantial unmet need in these countries, with the vast majority of adolescents going without any type of support. I want to move on now to the second study that I'm going to discuss today, which is the Global Early Adolescent Study, or GEAS. So whereas NAMS focused narrowly on adolescent mental disorders, the GEAS has a much broader scope, with an interest in understanding the role of gender socialization in shaping health and well-being among adolescents. And it's also designed to shine a spotlight on early adolescence, or ages 10 to 14, which is an age group that's often left out of global research into adolescence. The overall study design is a longitudinal study following early adolescence for up to 5 years within a large and diverse group of low-resource urban settings, as you can see here. So the GES is quite a large study, and there's a lot of important findings that we have around adolescent mental health that I could talk about here. But in order to paint a slightly different picture than what we just saw from NAMS, I want to focus in on a cross-sectional analysis of baseline data from 4 of our study countries: DRC, Malawi, Indonesia, and China. In this particular study, we conducted a latent class analysis to characterize patterns of emotional and behavioral problems among early adolescents across the 4 included countries. The emotional problems included symptoms of depression and anxiety, and the behavioral problems included indicators capturing both interpersonal aggression and substance use. You can see the final results from this analysis in the graphs on this slide, where each line represents a latent class with separate patterns of emotional and behavioral problems. On the x-axis, you can see the emotional and behavioral problem indicators, where 1 through 5 are the emotional problems and 6 through 10 are the behavioral problems. And on the y-axis, you can see the item response probabilities within each class, which range from 0 to 1. So without getting too much into the weeds here, let me just share what I find most striking about these results. And that's that while there were definite cross-country variations, 4 fairly consistent patterns emerged across these 4 countries. So these include up to 62% of adolescents across countries who had a low likelihood of both emotional and behavioral problems, which is pictured in the blue. But it also includes up to 29% with emotional but not behavioral problems, which is in orange, up to 22% with behavioral but not emotional problems, which is in green. And finally, a small but significant percentage, around 4 to 15%, with both emotional and behavioral problems, which is in yellow. Now, of course, with 4 very different contexts, we can't ignore the differences here. So, for example, there doesn't appear to be a robust group of adolescents in China with behavioral but not emotional problems. But without brushing these types of differences aside, I think that in essence, what we see here is that when we start looking at mental health symptoms that don't necessarily rise to the level of psychopathology, a large percentage of adolescents have non-specific or transdiagnostic symptom manifestations, whether these are purely emotional, purely behavioral, or some combination of both. And this certainly tracks with our current understanding of how mental health challenges actually emerge during early adolescence. And it suggests that we should be thinking more expansively in our approach to screening and into early intervention at this age. So now let's move on to the final study, which takes much more of a bottom-up approach to understanding adolescent mental health globally. And as a result, I think it can help us to contextualize some of the findings from both NOMS and the GEAS. This study was initiated as part of UNICEF's 2021 State of the World's Children report, which focused on child and adolescent mental health. And given our adolescent-focused work, UNICEF asked the GEAS to provide primary qualitative data on adolescent mental health from a diverse group of countries in order to help enrich the report. We were guided by three broad research questions for this qualitative study. We wanted to understand adolescents' perspectives on significant mental health challenges for people their age, key risk and protective factors, and principal coping strategies, including both barriers and facilitators to help seeking. So unlike in NOMS and in the GEAS, in this study, we really wanted to develop an understanding of adolescent mental health guided by adolescents themselves. And in order to answer our three research questions, we collaborated with partner organizations in 13 countries to carry out a series of 71 total focus group discussions with adolescents. And as you can see on this map, we intentionally selected a group of countries with very broad geographic, economic, and cultural diversity. As you can probably imagine, given the breadth of our research questions and the large number of focus groups that we held, this study really yielded rich data on a wide range of topics with relevance to adolescent mental health. But right now, I want to return to the three main messages that I mentioned earlier, which really emerged as key overarching themes that cut across our findings. So as you may recall, the first main message related to the distinction between distress and disorder. And what we found here is that adolescents often describe, understand, and communicate their mental health challenges in terms of distress, not in terms of disorder. So for example, sadness, stress, or defeat, rather than depression, anxiety, or PTSD. I think this is really powerfully illustrated by this quote from an older girl in Egypt who said, "Being tired psychologically means that you feel that you are not living life and are unable to do anything and are bored, keeping to yourself, and you don't want to deal with anyone. Even if you are ambitious, you will not be able to achieve your ambitions because you are psychologically totally defeated." Now, it's not surprising that a general sample of adolescents would largely use non-clinical terminology when discussing mental health. But that being said, I think that it speaks to the limitations of framing adolescent mental health challenges entirely through the presence or absence of discrete diagnostic categories. It particularly suggests that taking this type of purely diagnostic clinical approach may actually exclude many adolescents who are in fact really in need of support. And that above all, we really have to listen to and use the language of adolescents themselves when attempting to address their mental health. A second overarching finding related to the importance of context in which adolescents live, grow, study, and play in shaping their mental health. And for many adolescents, in the way that they talked about these issues, it was clear that mental health challenges are often completely entangled with underlying contextual conditions. So for example, adolescents discussed the ways in which mental health challenges would stem from family adversities, physical and sexual violence within their communities, profound conditions of poverty, stressful academic environments, restrictive gender norms that both devalued girls and precluded boys from expressing their emotions, damaging social media culture, and of course, COVID-19. And what was abundantly clear across these focus groups is that improving adolescent mental health requires attention to these contextual factors. For example, this older boy in Malawi described how poverty, school restrictions, and peer violence could intersect to impact mental health. He said, "At school, there are rules that everyone should dress up completely. You need a good shoe. You find that at your home, they cannot provide that for you, and you are putting on Crocs. Others, they get that crock and start throwing it at each other. Look at this, and the whole class starts laughing at you. It is so painful for us young people. So without any emotional or psychological support, that is when you hear that a student has committed suicide. Above all, we heard that adolescents around the world need much better formal and informal support to address their mental health challenges. I think it's important to mention that family and peer support arose as a powerful buffer against these challenges, and that in the best cases, these informal sources of support can serve as gatekeepers in connecting adolescents to more formal services when needed. That said, it was abundantly clear that adolescents generally would like more support than is often forthcoming. In particular, adolescents reported frequently masking their mental health struggles due to worries about invalidation, judgment, or ostracization, which is clearly related to deep stigma regarding mental health, which exists around the world. And as a result of this type of stigma, many adolescents describe coping without sufficient support. For example, this younger girl in Jamaica said, "I know a lot of people who have been going through situations where they are depressed, and they don't tell their stories, they don't talk to you about it. Every day that you see them, they have a smile on their face. They try to behave as normal as possible so that you don't ask questions." So when we look across this type of global data on adolescent mental health and well-being, how do we reconcile these different findings and these different approaches? I think that the key takeaways really lie somewhere in the middle. First of all, I think it's clear that we need to address distress alongside disorder among adolescents globally. The NOM study emphasized that while a minority of adolescents may suffer from psychopathology in certain contexts, these young people are still present and in need of support. But I think we also saw from the GEAS that symptoms in this age group don't always fall neatly into diagnostic categories. And the UNICEF study made it quite clear that even when distress doesn't rise to the level of psychopathology, it doesn't lessen the pain that adolescents experience. Second, adolescents need access to affordable, confidential, and youth-friendly services within their schools and their communities. And that includes targeted mental health services for those with diagnosable mental disorders, but it also includes general psychosocial support to address distress before it escalates. It may not be surprising, but it's still striking that fewer than 12% of adolescents with a mental disorder in NOMS had access to any type of formal support. And we heard a parallel message in the UNICEF study where adolescents described hiding their struggles, in part because of deep stigma. So clearly, major barriers to help seeking persist around the world. Finally, and perhaps most importantly, we need to tackle the many social and environmental conditions that give rise to mental health challenges in the first place. We began today by talking about a potential youth mental health crisis. And I think that how we understand this as a crisis really depends on whether we acknowledge the broader contextual factors shaping and challenging young people's well-being around the world. And so if I leave you with one last thought here, it's that upstream strategies must be central in order to see real progress. Before I pass things off to Jennifer, I'd just like to acknowledge the immense amount of work from partners around the world, as well as the contributions from young people themselves that went into all of these studies. So you can see the partners there. It's a long list, and it'll take me another 20 minutes probably to read them all. But with that, that's all.
Now we have Dr. Jennifer Seager with her presentation. Thank you so much.
Thank you so much. Excuse me, I'm getting over a cold, so I will hopefully be able to make it through without too much coughing. All right, so thank you so much. This is a great sort of transition from Shoshanna's presentation to mine. So I'm Jennifer Seager. I'm an associate professor in the Department of Global Health at George Washington University, and I'm also a quantitative researcher on the Gender and Adolescence Global Evidence Program, from which I'll be sharing some findings today. So just a brief outline of the presentation. So I'm going to be starting with sort of a broad overview of GAGE and their conceptual framing and how we think about psychosocial well-being. And then I'm going to dive into some findings from one of the several data collection activities that Gage engages in to talk about some measurement and age disaggregation in mental health. Then I will talk about gendered experiences and how looking at with this gendered lens can be very important in understanding how to address mental health concerns for adolescents. And then I'll end with what I see as some key takeaways. So Gender and Adolescence Global Evidence is a 10-year mixed methods program that is doing longitudinal research with 20,000 adolescents across 7 locations in the Global South. It aims to generate new evidence on what works to transform the lives of adolescent girls and boys to enable them to move out of poverty and to encourage social change. And I think what's important is that in Gage, we combine both this quantitative research as well as robust qualitative findings to sort of build an overall picture of adolescents' lives. And core quantitative work is ongoing in Ethiopia, Bangladesh, and Jordan. And I'll be presenting some findings from Bangladesh today, but that also sort of are patterns that are seen across all sites. And then I think you'll see echo strongly the previous presentation. So within Gage, we have a conceptual framework that covers adolescent experiences across 6 capability areas, and psychosocial well-being is one of those. And so what I'm showing here is Gage's overall conceptual framework for how we think about adolescent psychosocial well-being. So this framework outlines the problem of inadequate knowledge, right, and how to address these issues and what programming may be most useful. As you move up in the conceptual framework, we focus on what are the change pathways to improve adolescent mental health and well-being, which includes empowering boys and girls, supporting parents, community social norm change, and then strengthening school systems and adolescent services. When we think about psychosocial well-being, as stated, earlier, considering the context is incredibly important from the household level to your local communities and at the national level in which adolescents live. And importantly, along the side of the framework, you can see that when Gage is conceptualizing psychosocial well-being, we're trying to capture sort of multifaceted aspects, including not just measures of psychological distress and emotional resilience, but also capturing family and peer support, substance use, and access to quality psychosocial services. So as I said, today I'm going to be primarily presenting findings from one of the Gage studies, which is taking place in Cox's Bazar, Bangladesh, and I'm going to be particularly focusing on a sample of adolescent boys and girls who are refugees, Rohingya refugees living in camps in Cox's Bazar. As a brief background, just because I think the context is important as we're looking at these numbers, the Rohingya have resided in Myanmar's Rakhine state for generations, but have long faced persecution and violence, and have been de jure stateless since the 1980s. There have been waves of migration into Bangladesh since the 1990s, but most recently, and the largest wave occurred in 2017. And the data in this presentation comes from baseline data collection that occurred in 2019, about a year and a half after this wave of violence and migration, and when adolescents were aged 10 to 18, and from 2023, when adolescents are 19 to 22. All right, so to kind of talk about psychosocial well-being in adolescence, I wanted to start by just looking at a very simple measure of psychological distress using the GHQ-12. And there are 2 patterns that I want to highlight in this figure. So the first pattern is that we can see rates of psychological distress are increasing throughout adolescence. So we have first the 2019 findings looking at 10 to 14-year-olds separately from 15 to 18-year-olds, and then we present the same statistic among the same adolescents in 2023 when they're aged 14 to 18 and 19 to 22. And you can see for both age cohorts, rates of psychological distress are increasing between 2019 and 2023. And I think part of what I want to highlight here is then the importance of intervening early when we start to see symptoms of psychological distress because of how these build onto each other as adolescents age. The second pattern requires taking back into mind the context here, which is that we see that in both time periods, the adolescents who are 15 to 18-year-olds in 2019 are exhibiting much higher rates of psychological distress than those who are 10 to 14. And if we remember, our 2019 baseline is about a year and a half after this big wave of violence and migration. And the adolescents who were 15 to 18 in 2019 were then about 13 to 16 at the time of this displacement. And I think it's important then to think about how traumatic events occurring at sort of key windows of development are sort of critical to keep in mind when we're thinking about addressing mental health crises. I have a couple other figures here with some statistics looking at two other measures of psychosocial well-being that we capture within the GAGE study. The Patient Health Questionnaire, PHQ-9, and General Anxiety Disorder 7, GAD-7. And again, what I want to highlight here is that if we focus on rates of moderate to severe depression and moderate to severe anxiety as defined by the standard cutoffs on both of these questionnaires, we see relatively low rates of depression and anxiety. Among the 14 to 18-year-olds, we're looking at about 3% exhibiting moderate symptoms of moderate to severe depression and 1% or 2% exhibiting symptoms of moderate to severe anxiety. However, if we expand this out and look at adolescents who are experiencing any symptoms of depression or anxiety, we can see that around 30% of adolescents are experiencing moderate to severe depression, or 20 to 30%, and similarly around 20% are exhibiting some symptoms of anxiety. I think it's important to understand this when we're considering where and to whom programs or services are directed. That although we see sort of low rates at these acute ranges, sort of the numbers of adolescents that are experiencing distress is quite large. In addition, although this data doesn't necessarily suggest this, but some ongoing work I have in the Rohingya population is suggesting that part of what we're seeing here is that standard cutoffs on these scales are not capturing all cases that are meeting sort of the diagnostic criteria for depression. And in fact, some of that preliminary research that we're doing to sort of validate the PHQ-9 in this population is suggesting that whereas the standard cutoff is around 10 on this PHQ-9 scale, if you're familiar with it, it should really be lower at around 6 or 7 if we want to be capturing cases. So now I want to spend a few slides thinking about the importance of also looking at the sort of youth mental health crisis through a gendered lens and the way that boys and girls are experiencing adolescence differently. So first, what we find in GAGE is that girls are exhibiting lower emotional resilience than boys using a child and youth resilience measure. And so we can see in this figure that girls are both more likely to be exhibiting low resilience, as well as much less likely, right, to be exhibiting high resilience than their male peers. This is partially reflecting what this tool that we use captures, which is not just how the respondent responds to stress, but also the sources of support that they have to help them respond. And one of the key things we see in the Rohingya population, but also is echoed in other populations in the Gauge study, is that as girls age into adolescence, they lose many forms of social support because of being confined to home due to strict gender norms. So among Rohingya, once girls hit menarche, they really are confined to the home. They aren't allowed to attend school or other sort of social support clubs, and are therefore prevented from interacting with peers and adults in the community. And we have some quotes here. The last one, everyone feels upset once they have the first period. Suddenly they can't go outside and have to remain inside their home day after day. It is exhausting. We see this play out also, lower social support play out also in parent-child relationships. We find that girls are less likely to have support from their parents and other adults in the community. We find that they're less likely to speak with their parents about a number of topics, including school and religion. And what I have highlighted here is that, less than a third of girls report talking about their dreams and aspirations with their parents, compared to nearly 60% of boys. Similarly, we see that girls are less likely to have a trusted friend than boys, and that the gap in these rates increase as girls age into older adolescence and young adulthood. And this is perhaps unsurprising due to their confinement to homes in this community. It's also important when we're thinking about sources of distress to take this gendered lens. So both male and females, one big source of distress is assuming adult roles, but the way in which this manifests looks a little different. So for girls, this distress results from being pushed into these adult roles before they're ready, for example, due to early marriage, and experiencing gender-based violence and partner violence. And you can see some quotes of these experiences. One that I'll read, because they married me off at 14 years old, I even drank Dettol, which is a concentrated antiseptic solution. And that was from a conversation with a woman who is now, young woman who is now 22. For males, this anxiety and distress comes from assuming adult roles, taking on economic burden for their families, but also being denied education opportunities to learn. And one of the main consequences of this for males in this community is that they turn to substance use. So we can see a couple of quotes here. For example, those who are studying understand things. Those who are not studying are bad. They roam the streets, they do not work, smoke cigarettes, consume marijuana, trade stolen yaba tablets, and engage in illegal activities, sort of highlighting these experiences. And then finally, again, taking, I guess I got off on my slides at some. So finally, I wanted to make this point, which is also where Shoshanna ended on access to psychosocial support services, is that we also see gendered access to and knowledge of these services as well. So we have around 40% of females and 50% of males are aware of psychosocial support services, but among those, only 7% have ever accessed them. So again, seeing sort of low access, and particularly so for females. And apologies, I'm missing changing the actual slides. So to conclude, I think 3 key takeaways that I think would be ripe for discussion and that I see here is, first of all, I think it's important to have this age disaggregated data within adolescence to characterize youth mental health crisis. And I think we saw this in previous presentation as well with the GES study. Similarly, I think taking these gendered lens to understand adolescent experiences and sources of support are incredibly important when we're developing programming to address mental distress. And finally, I think because of challenges in measurement and diagnosis and even stigma around the discussion of psychological distress, I think it's important to capture a variety of measures as well as have conversations with adolescents themselves in order to understand adolescent well-being and develop the best strategy to provide support services. So I will conclude there. Thank you very much.
Can you all hear me? Thank you so much for the wonderful presentation. We have less than 15 minutes for questions. I took down some notes. However, some of those conversations will happen across, the presentations and panels. But I want to start with a priority message. We have a message for you all in the audience today, and this message or these messages are coming from the adolescents and the young people that Dr. Seager and Dr. Fine work with. Dr. Fine, can I start with you? Could you please share that important message that these adolescents have for the audience?
So, yeah, okay. Well, I am no longer an adolescent myself, so I hesitate to speak for all adolescents, but I think we heard it really powerfully earlier, this idea of nothing about us without us. And, I think we see there's a lot of attention given to this idea now of lived experiences and bringing in youth voices into mental health research. And I think we don't see a lot of initiatives that don't have that as part of it. But it is much harder to actually do well than it is to just sort of, give lip service to it. And so I think that we, here in the room, who many of us are no longer adolescents, need to think a lot about when we're starting any kind of initiative, what does it really mean to include youth voices? What, are we actually including youth voices? Are we just asking one young person or a couple of young persons, what they think, or are we truly incorporating sort of from the research all the way through to practice? And so so I think that's a long way of saying nothing about us without us. I think that's the big one.
Thank you so much. Dr. Seager?
Yeah, I think not too much to add from that. I think really echoing the work that we've done with Gage, and especially through the qualitative work, is what's become very clear is I think the these adolescents that we're working with really want the space to be able to talk and share and get support from others. And I think in some cases, when we're talking to young women who experienced early marriage, like this is one of the first forums where they've actually even been asked, how, what their experience has been and how they feel about it. And so I guess just really echoing everything that
Thank you so much for sharing. And I hope you all got the message. Did we? Thank you so much. So I have a question for you, Dr. Seager. When we talk about gender responsive or gender transformative programming, what does that look like in a practice for adolescents' mental health? Can you please share some examples where shifting norms or structures have improved mental health?
Yeah, so I think, it's a big question, and I think there's a lot of ways to answer it, and maybe I'll provide some examples of some of the work that we're doing with Gage and in Bangladesh, and also specifically with the community. I think one of the key, first steps is, of course, having the data and understanding adolescent experiences, both as a whole, but also through this gendered lens. And then I think the second thing is developing programming that really allows for communication within communities. And so one of the programs that we've been sort of piloting in the camps right now is a program that's developed called Girl Rising, that has been developed in other settings, but it's really focused around understanding, challenges, particularly for adolescent girls, and accessing education and having independence, and sets up a curriculum to have communication, not just with adolescents, but also with parents around sort of the norms that uphold some of those challenges to create dialogue in the community and conversations. I think that's one way to think about developing programming. But of course, I know we could have a very long conversation on this. And we are seeing some, we see that girls that have participated in the program are very happy to be having the conversations. And again, I guess echoing what I was just saying previously, having the space to have some of these conversations, because I think, one of the challenges we see is just, a lack of talking about it in general, right? And so I think this is like an important first step.
Dr. Pine, do you have anything to add? Okay. I have a question regarding measurement. And how should we prioritize meaningful measurement so that we do not miss young people who are struggling, especially across different social and cultural contexts? Dr. Fine, do you want to take that?
Yeah, sure. I think that we have been for years in mental health and youth mental health relying on the same tools for measurement of young people's mental distress. We talked about the PHQ-9. I showed the DSM, the DISC-5. We've been relying on those tools for years. And I think we in the research community have also known for a long time that those tools don't always work that well with young people, that they were designed in Western contexts, that they were designed in many cases in clinical populations, and that they were designed with adults. And that mental health in adolescence can look really different, and that developmental trajectories can look really different between two young people. And so, I know that we have a whole panel, I believe, tomorrow on measurement. So I'm hoping that we'll hear a little bit more kind of about the details of that. But I think that there's my feeling is that we know that these don't work. But we still use the same things because we don't have any better options. And so we need to kind of figure out what are those better options look like. Some of that is listening to young people themselves, right? Using the language of young people when we're actually asking them about their mental health. Thinking, differently maybe about what a cut point for distress or disorder actually looks like. And yeah, really sort of taking to task the idea that we need to do better, and we kind of need to make a commitment to better measurement around the world.
Thank you so much. Dr. Seager, do you have anything to add to that?
No, I think that I captured it well.
Thank you so much for listening. I did write down some key messages and summary for everything that we've discussed. However, before I get to that, I would like to open it to the floor for questions, if you do have any. We have the mic on both sides.
Thanks. Both presentations were quite illustrative on the need to differentiate between the stress and disorder, and also both presentations emphasizing the need to keep in mind context in order to understand the challenge that we are facing. But as part of the context, I think that perhaps there is a need also to understand the role of culture. The culture not only in terms of how you define a problem, how you understand the manifestations of the problem, but also is critical to define the type of solutions or the type of interventions that may be required to address the problems in accordance to how you define the problem. So I would like to get your views on this. Thanks.
Thank you so much. Cultural context?
Yeah, I think thank you so much for bringing that up. I think culture is central in thinking about, to me, context and other things. And I think it plays, culture plays a role in a lot of different ways, right? So think about kind of culture as being interlinked with measurement and the idea that there's cross-cultural variation in what we see in terms of important symptoms. But I think, we also see the way that culture plays in, I think you talked a lot about gender and gender norms, and that's deeply rooted, right, in cultural context and how that will. But yeah, I don't think we can disentangle, I guess is what I'm trying to say, the kind of culture from context here. And it does absolutely have to be central in the way we approach mental health prevention and intervention.
Yeah, and I think just to add, maybe a little more granular, but even beyond culture, it's also just thinking about language and what words different languages have to describe these feelings of distress. And I know in my work in Bangladesh, in fielding like PHQ-9 and G87, like a couple of the items, like what does it mean to be nervous versus worried, right? And does your language even distinguish between that? And even myself, if I were to try to explain, it would be challenging, right? And so I think that is also an important piece of this when we are thinking about measurement.
Thank you so much. We have 5 minutes, so please go ahead. I would like to balance it from both sides, if that's okay.
Hello again. I have my question quick. How do you utilize data from different cultures to incorporate in other places? Like you do research in like Bangladesh and those type of regions, and it's great work, it's super important, but the culture over there is very different from the culture in American culture or like the Western part of the world. So how do we go about utilizing all mental health research to incorporate in different cultures and different contexts?
I mean, I think one thing, and we could see it in, Dr. Fine's presentation is sort of like bringing together all of this data to try to see, one, what patterns emerge, but then I think, going back to the previous question is that while sort of overarching generalizable patterns are useful, I think, one thing that's sort of highlighted across both of our presentations and sort of what we were just discussing is that you can't really get away from some of these, the central role that culture plays in shaping these experiences in different settings. But I think, my big answer to your question is just getting more data and having sort of a broader set of information. Do you have anything to add?
Thank you so much for the question. We're going to take one more question.
Sure. I'll compound it. Thank you for continuing to do psychiatric epidemiology work. It's important. I haven't seen a lot of this in many years, so it's good to see that this continues. My question, actually, I'll ask both of them. It's real quick. I found it fascinating. I think, Dr. Fine, you had self-blame and looking at. I would love for you to say a little bit about that if you can, because it showed a lot of different impact on different risks. So I wanted to make sure we didn't lose that. And Dr. Seager, I was curious because of boys exhibiting greater emotional resilience. And forgive me if I missed this, I couldn't figure out whether or not boys had greater psychiatric or psychological distress or anxiety than girls. So I was just trying to put that in context. So thank you.
Yeah, thank you so much for that question. That's a great close reading of that very small figure on the slide that self-blame was one of the internalizing symptoms that we did look at. So thanks for that attentiveness. And, I think, and specifically actually the item we looked at is young people who said that they blame themselves when things go wrong, which, it's a pretty human thing to do, right? So we had quite a high prevalence actually across our young people. But I think also, as a mental health symptom speaks sometimes to that stigma that kind of came out in the qualitative data of young people who really, when they're struggling, they feel like it's all their fault that they're struggling, that they can't open up to anybody, that they can't share it, that, if they have some kind of mental health challenge, it must be their fault, right? And I think it gets back to what was so eloquently stated earlier around the sort of head and the body and the idea that we think physical challenges are something that is caused by something else, but who gave me ADHD, who gave me anxiety, I just brought that upon myself. So I think, again, I think it's when we look sort of below maybe disorder and look at some of these, parts of distress, I think that's something we see in young people really poignant around the globe.
Yeah, and so in the data that I presented for this population, when we're looking at sort of means of, say, PHQ-9 by gender, we see sort of, the means are higher for boys, but not statistically significantly so. So you could say in this population, we sort of are seeing similar rates by gender in that round of data collection. But really, like the higher emotional resilience that we're seeing among boys is really coming from this peer and social support network that they just have in this particular context much stronger than girls.
Thank you so much for answering the questions. I know we have said a lot here today, and I would like to conclude by summarizing some key messages from this presentation. So first, we'll start with better measurements can help us detect needs much earlier. Age disaggregated data, gender responsive tools, and measures that capture functioning and well-being can give us a more accurate picture of who is struggling. Secondly, mental health needs also shift across the phases of adolescence and are shaped by gender. When we design and report interventions with those differences in mind, we improve reach and effectiveness, which is crucial. We also need to address distress even if it does not meet diagnostic thresholds. This can still disrupt learning, relationships, and daily functioning, so support must be available in the places young people already are, with clear pathways into services when needed. And lastly, sustained progress depends on addressing the environmental factors that impact mental health. So in order for this to move on, we need to improve safety, inclusion, socioeconomic opportunity, which is just as essential as clinical and mental health and psychosocial support services. Thank you so much once again.